SEGM formed in response to the sharp rise of transgender identification among adolescents. We do our work because we believe that gender-diverse young people deserve a bright future. It has been said that if you want to define the future, you must study the past. So today my presentation will focus on the history of transgender medicine. People who defy gender norms have likely existed since the dawn of humanity. This graph shows the approximate number of transgender identified individuals in the United States, based on the best available data. There's one thing I know with certainty, and that is that this graph is definitely wrong. And this is because much of the data in the field of transgender medicine is highly unreliable. However, we do know today that 1 in 20 teens and young adults, almost 5%, identify as transgender or gender diverse. How to best help these young people, and whether continuing to offer them transgender medical interventions as the first line of treatment, despite a lack of reliable evidence of benefits and solely based on the principle of patient autonomy, has become one of the most heated debates of our time. The history of transgender medicine began here in Berlin under the leadership of a gay rights advocate and physician, Magnus Hirschfeld. Magnus Hirschfeld was one of the founders of the field of sexology. He founded an institute devoted to sexual science, established the first journal devoted to the study of sex, and made first films about variations in sexuality. He also gathered data on more than 10,000 men and women relating to their sexuality. He was one of the most prolific writers of his time, having written hundreds of articles and monographs, some under his name, some under a pseudonym. In 1910, Magnus Hirschfeld coined the term transvestite to describe individuals who cross-dressed. At first, he understood this group of individuals as a subset of gay men and lesbian women. However, as he began to study the group, he eventually concluded that they were distinctly different. In studying this group, Magnus Hirschfeld noted a lot of variation. Some of the individuals were satisfied with wearing the clothes of the opposite sex and being treated as the member of the opposite sex in public, at least for part of the time. But he also noted a group of patients who desired physical changes to their bodies. This group eventually came to be known as transsexuals, and currently we refer to this group as transgender. At his Institute for Sexual Sciences, Hirschfeld began to offer some of the earliest gender transition surgeries. The first documented case was a female-to-male patient in 1912. The first male-to-female surgical transition took place in the 1920s. After castration, the patient requested full genital removal, but the surgeon became nervous and instead tucked the tissue into the patient's perineum. It turned out to be a wise decision because shortly thereafter, the patient returned to the physician, asked for a reversal of surgery, and later lived his life as a physician and as a heterosexual man. By the 1930s, the advances in medicine led to the ability to synthesize estrogen and testosterone, giving physicians a lot more tools. However, by the 1950s, the known number of transsexual cases worldwide still remained very small. This all changed rather suddenly in 1952 with the case of the Danish-American Christine or George Jorgensen, who transitioned from male to female, and the headlines of this transition spread around the world rapidly. Before transitioning, George Jorgensen was a quiet, bright child, close to his grandmother, more interested in acting than rough and tumble play. He also liked to knit. He got bullied by classmates and even by his teachers for being too feminine. As a young man, he was quite feminine. People often assumed him to be gay, which embarrassed him deeply. When in medical college, George learned about the sex change procedures happening in Europe and traveled to Europe to pursue it. And then his coming out letter to his parents was leaked to tabloids, and within days, his story went viral around the world. Or at that point, her story went viral around the world. And so within months of George Jorgensen becoming Christine Jorgensen and the story becoming public, first tens, then hundreds, and then thousands and tens of thousands of people began to present to physicians asking for similar kind of sex change surgeries and often referring to the case of Jorgensen. As soon as the name of the physician who treated Jorgensen, Dr. Christian Hamburger, became public, Dr. Hamburger, a Danish clinician, began receiving hundreds of letters from people all over the world. Most of them were men, some were women, and there were even a few teenagers, all describing their wish to undergo the similar procedures that Jorgensen had undergone. In 1953, Dr. Hamburger published an analysis of these cases in a medical journal. He noted that there was an overrepresentation of same-sex attracted men, although there were a lot of heterosexual men. There was a small number of women. All of them wrote to Dr. Hamburger, sharing with him that they were same-sex attracted. Dr. Hamburger also wrote up Jorgensen's case separately for the Journal of American Medical Association, or JAMA, in 1953. In the article, he described Jorgensen as having female psyche that can only be helped by helping George transition and live as Christine, a woman with hormones and surgery. It was not until nearly 30 years later that a team of Danish researchers accessed Jorgensen's medical records and discovered that while Jorgensen definitely wanted to undergo sex change, the medical team did not originally intend to perform a sex change operation. They went on to describe that the original intention of the medical team was not to change, and here I quote, not to change a man into a woman, but to help a man who suffered from his homosexual impulses. It was not until afterwards, when the press published the case, that the team that performed the procedure began to position it as a sex change. And the rest of this history now is well known. Through a series of historical twists and turns for which we have no time today, it was the Netherlands that became the first country to offer adult gender transitions at scale in a respected academic medical center. It was also fully covered by the national insurance. As a result, by the late 1980s, the Dutch clinicians gathered enough outcomes to publish a research study. In this study of 141 adult patients, the researchers reported that the patients had high levels of subjective satisfaction, but objective outcomes were concerning. There was also a high post-transition suicide risk that the researchers identified as a critical signal. They also found one other surprising finding, that patient satisfaction did not change based on the treatment stage, whether the patients were just starting hormones, were mid-treatment, or post-surgery. There was also a nearly 40% dropout in the research. They concluded with a fairly sober conclusion that sex reassignment surgery is not a panacea, does not solve all problems, and could create new problems. And they recommended better psychological support for patients going forward. They also noted that younger patients those who underwent the procedures before the age of 30 seemed to have better outcomes. They did not seem to consider that those patients in their own study were predominantly females. And so there was a sense that was created that younger transitions perhaps would lead to better outcomes. However, the leap from adult transitions to youth transitions happened through happenstance. The same researcher that published the adult outcomes was transferred to a children's division in the hospital and began to treat children. There she observed that there were a number of young people who were quite gender nonconforming and some of them lived as boys already. She admitted that as a therapist, she hit a wall in therapy with them, and therapy was not helpful. And so, based on her experience with adult transsexuals, she saw no reason to deny these patients hormones until the age of 18, and because of Dutch consent laws, at the age 16, consent was possible, and so patients were allowed to start taking cross-sex hormones. But then there was another significant happenstance, and Michael Biggs, who will be speaking after me, will probably speak to it more, but the same clinician, Peggy Cohen-Katenis, in her clinical practice encountered a patient that had already been treated by a different endocrinologist outside of the clinic with puberty blockers off-label. And that patient presented to her with a very convincing boyish male appearance. And at that point, the team got the idea that perhaps now that cross-sex hormones were lowered to the age of 16, there is now a new treatment that could start it much earlier, which is puberty blockers. And that is how the Dutch protocol was born. The Dutch protocol, as we all know, is or some of us have studied quite a bit, is based on the rationale that earlier transition will lead to better outcomes, as compared to somewhat disappointing or sometimes very concerning results of adult transitions. And the key element is that the puberty blockers were introduced. The focus has always been on identifying those future true transsexual patients. So the Dutch team developed a set of criteria that they thought would be predictive of who would be a future transsexual. And ultimately, the key assumptions were that there would be a relief of suffering, puberty blockers were a harmless pause, giving time to think, better cosmetic outcomes would lead to less stress and perhaps better future mental health outcomes. Those were effectively the premises of the Dutch protocol or the early intervention model. The short-term outcomes of 70 patients treated under the Dutch protocol were published in 2 studies between 2011 and 2014. The studies reported on improvements in adolescent mental health and concluded treatment was a success. And these papers became the foundation of the gender-affirming care model that we know today and remain to be its strongest evidence base. But a closer look reveals pretty significant problems in the outcomes that were already reported as far back as 2011 and 2014. For example, the psychological improvements that were statistically significant actually were in subclinical ranges, usually just 1 to very small improvements before and after treatment. And importantly, the signals of harms seem to have been overlooked. One patient died from surgical complications, likely due to insufficient penile tissue after early puberty blockade. That is something that the researchers later reported in an unrelated article. At least 3 patients developed severe diabetes and obesity. At least 1 appears to have discontinued treatment, possibly detransitioned. And those cases were reclassified as non-participant and not really reported in the outcome tables. Also, but 1 patient were same-sex attracted. There is also another striking finding in the Dutch study, and I wanted to spend a couple of minutes explaining it, but I also don't know how I'm doing on time. Is anybody timekeeping to tell me how much time I left? Okay. So this is a really important point to understand. So arguably, the Dutch study launched the practice of youth gender transitions not because of mild psychological improvements in subclinical ranges before and after treatment. It was because it was reported a remarkable resolution in gender dysphoria itself. But when you look at the scale that was used to report this improvement, one can't help but ask very serious questions. So this is a scale. I don't know if you can see it, but I will just choose one example. So effectively at baseline, patients got a version of the gender dysphoria questionnaire based on their birth sex. However, after transition, they were given the opposite sex scale corresponding to their target gender. In a way, this made sense because the patients were no longer living in their original sex. But that created major problems for the scale, rendering it, in my opinion, invalid. And I will just give you one example. At baseline, all females had to rate the question, every time someone treats me like a girl, I feel hurt. After surgery, they would rate the question, every time someone treats me like a boy, I feel hurt. Naturally, a gender dysphoric girl would score the maximum score, 5, pre-treatment, since she feels very hurt about being treated as a girl. But after transitioning, she's now answering the boy version of the question and would naturally score a 1, since, of course, she likes being treated as a boy. This is what she wants. So this dramatic drop in gender dysphoria from 5 before treatment to 1 after treatment looks like a huge improvement from the maximum to the minimum, but actually it's just a predictable result of reversing the question wording and scoring. If you ask the same girl both questions before and after transition, her scores would already go from 5 to 1 without any medical interventions. So despite all the limitations in the Dutch research, the protocol began to spread worldwide. In 2012, it was incorporated into Standards of Care by WPATH, Standards of Care 7. By 2017, the Endocrine Society made it a core part of its guidelines. And perhaps coincidentally or not, as the treatment became widely available, more and more teenagers began requesting it. This trend became especially evident around 2015. This graph you see is from the UK, but every Western country is reporting a nearly identical trend. And we now see that the same pattern also appears in the youth of aged 18 to 25-year-old. But unlike the classic Dutch cases, these new patients have no childhood history of gender dysphoria. They report very high rates of pre-existing mental health issues. They have significant neurodevelopmental diagnoses, and very importantly, all these problems predate the onset of their gender distress. We're also now starting to see growing detransition rates. Traditionally, they were presented as being around 1%, but we are now seeing in this new cohort detransition rates anywhere between 10 and 30%, and after just a few years, and with a significant number of young people speaking openly about the regret of irreversible interventions. So this, you can really go back to this graph and see how sharply this curve bends around 2015. There were multiple attempts to replicate the success of the Dutch protocol, and they failed. The UK Gender Clinic found no mental health improvements when they attempted to replicate the study. We now know that the US NIH-funded study also was unable to report any positive outcomes for puberty blockers. For cross-sex hormones, the study did report some mild outcomes, but some mild improvements at very uncertain, very low quality evidence. And alarmingly, it sort of noted almost in a kind of a casual way that the most common adverse effect during the treatment with cross-sex hormones was suicidal ideation. And in fact, 2 out of 315 patients committed suicide while being treated in this NIH-funded study. We're now starting to see the data about some long-term outcomes of the patients. This is a graph based on US insurance data with the persistence of gender dysphoria diagnosis. You could see that within about 50% of the youth lose their diagnosis 7 years later. Very similar research came out of Germany with even more marked decreases, even less stability in the diagnosis, which raises a question. If we're treating a condition that does not persist for many patients with medical interventions that are permanent and irreversible, what proof, what evidence are we using to offer these interventions at scale? All of you probably know about the CAS review, which have found the research to be remarkably weak. And I just want to conclude by saying that before I came here, I was at the EPATH conference, European Association for Transgender Health, where it was openly acknowledged. EPATH clearly really believes that the patients should be, these treatments should be offered widely based on the autonomy principle, the patient's right to demand a treatment, because they genuinely believe that these patients need the treatment. However, one of the prominent gender clinicians there spoke about the fact that the need for the treatment is not in vacuum, but is shaped in large part by what treatments are on offer. And so, whether these treatments should remain on offer and arguably virtually on demand is what we will be discussing later today. Thank you.